Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my videos are for educative purpose. Today we'll be discussing on one of the another interesting topic in neurology, that is peripheral neuropathy. It will be very useful to you in your exam, theory as well as oral, and also it will be very useful when you go for your private practice. Good number of time we get confused. What is the lesion, where is the lesion, and why there is a peripheral neuropathy, and what exactly is the reason for peripheral neuropathy, what is the etiology, what type of peripheral neuropathy, etc. You can see here in this first picture, there is only one portion of the body is being involved, that is right upper arm, and also in right upper arm, forearm, and even in forearm, a very small portion is being involved. This means it is at least not involving the complete right side of the body, so it cannot be central nervous system, because usually in a central nervous system we get involvement of entire half of the body. Here it is only a small portion of the body, so it is less likely to be brain, less likely to be brainstem, less likely to be even spinal cord. So it goes more for peripheral nerve, so it is mononeuropathy. You can see here similar type of lesion is seen in right upper arm, right lower limb, and left. And if you see the difference between these two, this is entire portion is being involved. This is a small portion is being involved. So this is one group, second group, third group. So it is called mononeuritis multiplex. Here the entire limb is being involved. This will be very commonly if you get good number of spinal nerves getting involved, which happens very frequently in radiculopathy, or we call plexopathy. And when you get glove and stocking type of involvement, it is typical of polyneuropathy. So these are some of the picture, and we'll be discussing how you identify, etc. So the most common symptom in a peripheral nervous system is the sensory symptoms like tingling, numbness, paresthesia, most common. So first, before we label that this is a peripheral neuropathy, you have to identify where is the lesion, whether it is in the brain, whether it is in the pyramidal tract, whether it is in the brain stem, whether it is in the internal capsule or in the spinal cord, or it is outside the spinal cord. When it is outside the spinal cord, we call peripheral nervous system. As far as the etiology is concerned, there are good number of different type of pathophysiology like genetic, idiopathic, vascular, mechanical, autoimmune, neoplastic, metabolic, infections, nutritional, toxic, etc. And to rule out that whether it is central or peripheral, we need CT or MRI, nerve conduction study, EMG. You want to look out whether the central nervous system is involved or not, you can go for EEG, lumbar puncture, and sometime even biopsy in case of peripheral neuropathy. So these are the general outline what can be utilized to pinpoint in peripheral neuropathy. So localization of peripheral neuropathy is very difficult because there are more than 100 causes of peripheral neuropathy, and if you want to identify without any investigation like this investigation, it is difficult. But if you take a good history, proper examination, you can come to the most closest differential diagnosis, and later on you require a selective investigation like nerve conduction study or EMG or biopsy. So we'll try to make it as simple as possible. So where is the lesion? If you want to identify what is the type of damage and why, that is etiology. We'll try to go through that. We know very well central nervous system, or we call nervous system, consists of central part and peripheral part. We are more interested in peripheral part. It can be sensory, it can be motor, and again in that somatic in both system, visceral in both system, and then we have got a third portion of peripheral nervous system, that is autonomic nervous system, which can be divided into sympathetic, parasympathetic. So what are the different parts which are in peripheral nerve? Peripheral nerve consists of spinal nerve roots, dorsal root ganglia, this is spinal nerve root, this is dorsal root ganglia, ventral root ganglia, common spinal nerve, then all the spinal nerve gets together to form plexus, and from plexus we got peripheral nerve trunk, and then it divides into three groups of fiber, one which supplies skin we call sensory nerve, one which supplies motor fiber to skeletal muscle we call motor nerve, and one which supplies the blood vessels we call as autonomic nervous system. So where is the lesion? If you want to find out, you will have to go through some of the common symptoms because they contain those particular fiber. Say if we take this particular nerve, this contains fiber which is going from sensory, that is from skin towards spinal cord. So it contains sensory, it contains autonomic nervous system, and it contains motor fiber. So whenever you get a damage to spinal nerve, you will have a motor finding, you will have a reflexes being affected, sensory system being affected, and also autonomic nervous system being affected. So anytime if you get these three things together, that is motor involvement, sensory involvement, and autonomic nervous system involvement. And again in motor, it will be mainly lower motor neuron type. You will never get upper motor neuron type when there is a spinal nerve or peripheral nerve is being involved. So that is characteristic. If you get only motor fiber, which is supplying a muscle, then you have got a myotome distribution. If you have got a ventral root involvement, there will be no root pain, very peculiar, and it will be a pure motor involvement, which will be in a distribution of this nerve root. Say if this is coming from C5, so whichever muscle is supplied by C5 root, those muscle will be involved. When you get involvement of this peripheral nerve, which is carrying the sensory fiber via the posterior root, or we call dorsal root, to the spinal cord, you will have a pure sensory, and it will be in the distribution of that root we call dermatome distribution. And if you get the involvement of this posterior root or posterior root ganglia, you complain of severe root pain, and there will be involvement of the sensory findings. We call this as a radiculopathy. And when you get involvement of the spinal cord, we call myelopathy. And usually in the spinal cord there are two portions. One we call as a gray matter, white matter. When white matter portion is being involved, we get involvement of different tracts. Say if you get involvement of the posterior root, posterior column, so you get posterior column involvement. You get an anterior column involvement, you will have an involvement of the anterior spinothalamic. And here you will have an involvement of lateral spinothalamic with corticospinal tracts. So this is called myelopathy. When you get involvement of posterior nerve root ganglia with spinal cord, then we call radiculomyelopathy. And if you get an involvement of this, what we call as a sympathetic ganglia, then that will produce autonomic nervous system involvement. So this is roughly the idea of peripheral nervous system. And if you take in a upper limb and lower limb, close to the shoulder joint, we have got the axillary nerve. Then we have got musculocutaneous nerve. We have got a brachial plexus. We have got a median nerve, ulnar nerve, radial nerve. So you should know this particular nerve supplies which part of the body and which muscles. So if I get involvement of the two and a half part, two and a half finger, that is thumb, index finger and middle finger, then it is carpal tunnel syndrome. Classical is median nerve compression. And if I get little finger involvement and lateral part of the palm, then it is ulnar nerve involvement. I get extensor muscle of the wrist getting involved. It is radial nerve involvement. So depending upon which group of muscle are being involved, you can identify which nerve is probably involved. Say I get deltoid being involved. It will be mainly what we call is a musculocutaneous nerve getting involved. So depending upon that, in lower limb you will come across what we call the lumbosacral plexus, that is obturator nerve, femoral nerve, sciatic nerve, common peroneal nerve, tibial nerve. You will have a lateral peroneal nerve, saphenous, etc. And you have got a brachial plexus which is supplying the upper limb, and you have got a lumbosacral plexus which is supplying lower limb. So depending upon that, but a classical finding we have already mentioned in a neuropathy. As far as the motor finding is concerned, you will have a lower motor neuron type of finding, that weakness, atrophy, we call loss of reflexes, hypotonia and fasciculation. So when you get lower motor neuron type of involvement plus sensory involvement with autonomic nervous system involvement, it is peripheral neuropathy. But in neuropathy you can have a pure motor, pure sensory and even autonomic nervous system involved. So depending upon the variety, you will get different patterns. But whenever you got a low motor neuron type of finding in the distribution of nerve or in the distribution of root supply, suspect peripheral nervous system being involved. So the interesting thing to find out what we call is where is the lesion. If it is a lesion in the spinal cord, you will get upper motor neuron type of finding. But when you get the lesion in the anterior horn cell or in this nerve root up to myoneural junction, it will be low motor neuron finding. But portion which is outside the spinal cord, that is nerve root, then we have got a plexus, peripheral nerve up to myoneural junction. This entire is called as peripheral nervous system. So that we call as peripheral neuropathy, or the word used is neuropathy. And in neuropathy, to differentiate from myopathy, weakness in peripheral neuropathy will be distal portion will be more involved, or distal muscle will be more involved as compared to proximal. While in myopathy, the proximal is more involved as compared to distal. As far as the deep tendon reflex is concerned, in myopathy it will be preserved, while in neuropathy, if that root is being involved, reflex, deep tendon reflex will be absent. And as far as sensory is concerned, in myopathy, no, it is not involved. While in neuropathy, if it is mixed nerve, it will be involved. And if it is pure motor, then sensory is not involved. If we go in little more detail, as far as the distribution is concerned, we already mentioned, in a neuropathy, it is more distal and it will be more symmetrical. While in case of a myopathy, we are more interested in these two groups, myopathy, peripheral neuropathy, neuromuscular junction and anterior horn cell. In anterior horn cell, it will be a low motor neuron type of involvement. It will be more distal. In myopathy, it will be more proximal and symmetrical. While in neuropathy, it will be symmetrical and distal involvement. While in neuromuscular junction, it will be single group of muscle will be involved, like extraocular muscle, bulbar muscle, pharyngeal muscle, etc. It is again more proximal. As far as atrophy is concerned, you will come across in anterior horn cell lesion, which is a lower motor neuron type of damage. as well as in case of peripheral neuropathy also it is a lower motor neuron type, but in neuromuscular junction and myopathy it is not affected, but in a late stages you might have little amount of atrophy. Fasciculation will be present classically in case of anterior horn cell, very common. It will not be seen in myopathy, it will not be seen in neuromuscular junction, and it will be present because it is low motor neuron type in peripheral neuropathy, but more frequently in case of anterior horn cell lesion. As far as reflex is concerned, it will be affected in anterior horn cell and in peripheral neuropathy, while it will be preserved in neuromuscular junction and in myopathy. Pain is not a common symptom in case of anterior horn cell, but in peripheral neuropathy it may be present. It will not be present in neuromuscular junction or myopathy. But in case of myopathy, when it is inflammatory type of a myopathy, then you might have a pain because of inflammation. Cramps is very common in case of an anterior horn cell, but by and large in a myopathy it is absolutely rare. In neuromuscular junction it is absent, and in a peripheral neuropathy, if motor system along with sensory system is involved, you might have a cramps. As far as sensory loss is concerned, in anterior horn cell it will be absent, in myopathy it will be absent, in neuromuscular junction it will be absent, but in peripheral neuropathy, particularly if it is a mixed nerve or pure sensory, it will be absent. And CPK will be elevated in myopathy. In case of neuromuscular junction, it will be absent or normal. Peripheral neuropathy, it will be normal. Anterior horn cell, it will be normal. But in an anterior horn cell, when you get a severe atrophy, wasting, you might have a slight elevation of CPK. This is a major difference. If you remember this difference, you will be able to differentiate in a peripheral damage, whether it is a myopathy, whether it is a neuromuscular junction, whether it is a peripheral neuropathy, or whether it is an anterior horn cell. Then you have to differentiate between nerve root, that is radiculopathy, plexopathy, or peripheral neuropathy. You will have to differentiate between these three. I have already mentioned, in radiculopathy, you will have a severe radicular pain. In plexopathy, it will be multiple nerve roots which will be involved, while in peripheral nerve, it will be in a distribution of peripheral nerve. And when you get involvement of radiculopathy with myelopathy, we call radiculomyelopathy. Classical example is subacute combined degeneration. So we already mentioned this particular difference, that is peripheral neuropathy and myelopathy. Tingling numbness will be very common in peripheral neuropathy. It will be also common. Hyperalgesia will be common in peripheral. Hyperesthesia is common in this, while in a myelopathy, only in case of inflammatory variety, you might have muscle cramps and pain. Sensory symptom will be absent in case of a myelopathy. Ankle jerk will be present in case of myelopathy. Sorry, this is myelopathy. This is not yes, it is not myopathy, it is myelopathy. In a myelopathy, you will have upper motor neuron variety. So reflex will be brisk. Plantar reflex will be extensor. While here in peripheral neuropathy, if nerve root is damaged, it may be absent, but by and large it will be flexor. Abdominal reflex will be present, while in a spinal cord involvement it will be absent. So this is a difference between peripheral neuropathy and myelopathy. Myelopathy means spinal cord involvement, and in spinal cord you get involvement of a corticospinal tract, hence you get involvement of upper motor neuron, and in upper motor neuron you don't get wasting, you don't get fasciculation, but you will have a upper motor neuron finding, means tone will be increased, hypertonia, reflexes will be brisk, plantar reflex will be extensor, that will be peculiar finding. Abdominal reflex will be absent because the one of the pathway is through posterior column. Now, little idea regarding a peripheral nerves, variety, etc. We call classification or types. Involvement of peripheral nerve can be motor, pure sensory, or a mix. And along with that, you can have autonomic nervous system involvement. Depending upon the etiology, you can have a etiological classification. We will be dealing in second slide. Depending upon the number of nerve involvement, we call mononeuropathy. Mononeuritis means multiple single nerve in different areas. We call mononeuritis multiplex. And if there are multiple nerve in the same area, we call polyneuropathy. If there is an involvement of the central system, we call central involvement and peripheral involvement. Then if there is a small area being involved, focal, multifocal, or generalized. If there is a proximal part of the nerve being involved, we call proximal. And if distal part is involved, we call distal. In distal, it is more common with peripheral nerve, while in a proximal part, it is more common with radiculopathy and plexopathy. It can be etiology wise, you can divide into congenital or acquired, and in congenital, it can be hereditary or sporadic. Depending upon the onset, acute, subacute, chronic, you can have a relapsing variety, you can have progressive groups, and you can have a remitting groups. Depending upon the type of fiber, we call small fibers, which are usually pain fibers and autonomic nervous system, while large fibers are usually mainly posterior column and motor fibers. Posterior column is we call tract of Gollenberda, and another group of large fiber is motor fibers. While small fibers are usually pain fibers and autonomic nervous system fiber. In between comes the fiber for touch and temperature. It can be symmetrical distribution, bilaterally symmetrical, or it can be one side more involved as compared to other side. We call asymmetrical involvement. Classical example of asymmetrical involvement is mononeuritis multiplex, while polyneuropathy will be symmetrical. Mononeuropathy is asymmetrical. We already mentioned in acute, subacute, etc. It can be static or it can be progressive, relapsing, or it may be in a stage of recovery. In a sensory variety, we can call that as a painful or painless. And depending upon the part of nerve, if axon portion is involved, we call axonal neuropathy, and if myelin is involved, we call it a myelin demyelinating neuropathy. And if neuron cell is involved, we call neuronal neuropathy. Etiological wise, by and large, one I put to this two. This will be acute variety like infection, immune, or we call autoimmune groups, compressive groups, and iatrogenic groups. These are common in acute variety, while other will go into what we call as a subacute or chronic variety like metabolic, and the most common is diabetes mellitus. Another common which you will come across will come slowly, that will be GBS. Then HIV is another common, leprosy, toxic, hereditary is not very common, we call Charcot-Marie tooth. Then paraneoplastic, vasculitis. In vasculitis again diabetes and SLE is very common. Nutritional, very frequently B1, B6, B12 deficiency, that is another very common. Compressive neuropathies are common. Iatrogenic are very common. And when we cannot put them into any particular group in spite of all possible investigation, then we put them into idiopathic group. There is another way they put vitamins, whichever way you remember. V for vasculitis, I for infection, T for trauma, A for autoimmune, M for metabolic, I for iatrogenic, N for nutritional, S for syndrome. And then comes other, that is called toxic, paraneoplastic, compressive, and idiopathic. Whichever way you want to remember. Now this is a very useful slide because I have marked some of the things. The most common cause of peripheral neuropathy in your everyday practice will be diabetes. Second common will be alcohol. Third common will be nutritional deficiency like B12 deficiency. And then comes GBS. This four comes topmost on the list. Another common is what we call as a compressive neuropathy. And again among those, carpal tunnel syndrome, sciatica, Bell's palsy comes topmost on the list. Hereditary is not very common. Another very common is infection like HIV infection and herpes. The another common is toxic neuropathy secondary due to drugs, very commonly like phenytoin sodium, Isonex, which can produce nerve damage. And you can have arsenic, lead, HIV, medications, chemotherapy, all those groups. While sarcoidosis, porphyria, amyloidosis, autoimmune group of disorders, endocrine disorders, Charcot-Marie tooth, they are not very common. This I've already shown you before, that this is classical, what we call as a mononeuropathy. This is mononeuritis multiplex. This is radiculopathy. This is polyneuropathy. This is again polyneuropathy. I've already shown you that before. Now to summarize one part of it, in diabetes you can get multiple different varieties of peripheral nerve involvement, like you can have a cranial nerve involvement, you can have a distal symmetrical sensory neuropathy, we call as a polyneuropathy. Distal symmetrical sensory and motor involvement, we call sensory motor neuropathy. You can have a small fiber getting involved, means you can have an autonomic nervous system being involved, along with sensory involvement, mainly touch and temperature getting involved. You can have an autonomic neuropathy. You can have a mononeuropathy variety or a multifocal, or we call mononeuritis multiplex variety. You can also have a asymmetrical proximal motor neuropathy in diabetes. Here, not a small fiber, you will have a big fiber getting involved or large fiber getting involved. And you can have a pure motor radiculopathy. You can see a wide variety of involvement. Indirectly, we say that any variety of neuropathy, first differential diagnosis is always diabetes mellitus. And you can also have involvement of brain, spinal cord also. So you should know diabetes very well and you should investigate for diabetes. 20 to 25% no etiology in spite of extensive and exhaustive investigation. Then we put this into a idiopathic variety. Very rarely you come across a group which we call as a Charcot-Marie tooth, in which there is a strong family history. There will be hemato, means deformities of lower limb, high arch, weakness at ankle, gait abnormality, etc. Do suspect Charcot-Marie tooth if you get a strong family history. So, localization without investigation, one, if it is pure sensory, there is no motor involvement, suspect diabetes mellitus and nutritional deficiency. If it is pure motor, less amount of sensory or almost no sensory, GBS, that is Guillain-Barré, and acute intermittent porphyria. If there is an autonomic nervous system involvement, with or without sensory and motor, diabetes. If it is a mixed variety, means sensory plus motor, again diabetes. You can see diabetes comes in sensory, it comes in autonomic nervous system. Pure motor is not very common, but even diabetes can come in a pure motor also, and even in a mix. And in a mixed variety, do suspect diabetes, and another is called subacute combined degeneration, which is because of B12 deficiency. If it is motor involvement, and if distal is more involved as compared to proximal, then suspect diabetes and alcohol. If it is a focal involvement, like say involvement of only one nerve, then do suspect nerve compression syndrome, or we call entrapment. Classical example, carpal tunnel, Bell's palsy, sciatica. If distal and proximal are both involved and rapidly progressive, GBS. If sensory system is mainly involved, we call more of sensory. We have already told you that you suspect diabetes and B12 deficiency, that is subacute combined degeneration. So now we divide in that sensory, small fibers getting involved. Small fibers means pain and temperature getting involved. and dip tendon reflex is normal. So motor is not involved. You suspect diabetes mellitus. Now if large fibers are involved, means posterior column is involved, rhombus sign positive with involvement of motor fibers, suspect subacute combined degeneration. And if only even posterior column is involved, then also keep first differential diagnosis as subacute combined degeneration, that is because of B12 deficiency. And in motor system, if it is low motor neuron involvement, power 0, there is atrophy, dip tendon reflex is absent, fasciculation is present, there is hypotonia, and peripheral nerve distribution. Suspect peripheral neuropathy. But if there is a upper motor neuron findings like hypertonia, there is little amount of power, dip tendon reflex is brisk, there is no wasting, and there is also lower motor neuron findings, then in that particular condition, suspect subacute combined degeneration. So onset wise, if it is less than 4 weeks, we call acute onset, always in favor of a vascular etiology, particularly vasculitis. And whenever you suspect vasculitis, two most common, that is diabetes and SLE. Another which is very acute, like nerve compression or after giving injections or diphtheria, these are again put into acute group. Traumatic, very common. Nerve compression syndrome, very common. Infections, certain infections, particularly what we call is a diphtheria, quite common. And post-infection, which is autoimmune variety, we call GBS. In a subacute variety, which is more than 4 weeks, again GBS comes because some of the cases of GBS can present with a slow duration, slow onset, and whenever it takes more than 8 weeks, we call it as a chronic, and in that comes chronic inflammatory demyelinating polyneuropathy, and even diabetes can present as a chronic. And there is one variety which can be relapsing, where the person improves in between and again gets an episode of involvement, we call CIDP, that is chronic inflammatory demyelinating polyneuropathy. While GBS is described as an acute inflammatory demyelinating polyneuropathy, AIDP. If there is a strong family history, it comes in early age group, symmetrical, foot and spine deformity, trophic ulcer, do suspect Charcot-Marie-Tooth. If there is a history of diabetes, very easy. And if there is skin lesions, and clinically you are diagnosing SLE and person has got nerve involvement, do suspect vasculitis is responsible in SLE for peripheral nerve involvement. History of alcohol is because of B1, B12 deficiency. Drugs history, Isonex and streptomycin, classical example. Previous history 2 to 3 weeks before the onset of nerve system involvement, peripheral nervous involvement, do suspect GBS. And say another example, if the person is involved in an ICU and he starts developing neuropathy, it is we call as infective neuropathy, very common, quite common, and good number of time it is because of a chronic infection. Person can develop a chronic inflammatory demyelinating polyneuropathy. Site wise, depending upon the area, if extensor side of upper limb is involved, radial palsy, very common, classical. Ulnar nerve palsy, Bell's palsy. Type of involvement we already mentioned before, sensory, motor, mixed and autonomic. We have already given you an idea regarding mononeuropathy, single nerve involvement, classical example, carpal tunnel syndrome. If you have got a multiple nerve involvement, single nerve involvement in different areas, mononeuritis multiplex, and you've got a glove and stocking type of sensory involvement we call the polyneuropathy. Depending upon the area being involved, if peripheral nerve is involved, peripheral neuropathy or peripheral neuritis, and if there is a radical which is being in your posterior nerve root, posterior spinal nerve root, we call radiculopathy, or anterior spinal nerve root getting involved. If brachial plexus, cervical plexus, or say lumbar plexus, plexopathy, and with radical with spinal cord involvement, radiculomyelopathy, and occasionally you get involvement of the central nervous system part, which is quite common in subacute combined degeneration, alcohol, diabetes, etc. And we have already mentioned in onset variety, subacute, acute, chronic, relapsing variety, remittent variety. And depending upon the part of the body being involved, we call proximal and distal, central and peripheral, etc. We have mentioned all these things. Most common symptoms are sensory symptoms, which can be in the form of burning, tingling, numbness, band-like pressure, tight pressure, painful hypersensitivity, or we call hyperesthesia. Paresthesia can be in the form of pain and needles, and when there is a loss, damage, loss of sensation, we call no sensation, or person will complain like block of wood. If motor system is involved, you get weakness. Distal is more as compared to proximal. Usually it is distal and symmetrical. In GBS, it can be distal with proximal. It can be unilateral limb weakness, classical in case of a brachial plexus or lumbosacral plexus. And unstable balance, that is posterior column involvement, mainly because of the large fiber getting involved in case of subacute combined degeneration, or we call nutritional deficiency, etc. So you can have a sensory symptoms like stocking and glove and stocking variety, motor, distal weakness and extensor more as compared to flexor, or you can have autonomic involvement like orthostatic hypotension, impotency, etc. In sensory, paresthesia, dysesthesia, hypoesthesia, and even allodynia. Signs wise, in sensory you will have a loss of pain and temperature, or loss of vibration and proprioceptive in a distal part more as compared to proximal. This is very peculiar. In a motor also, the distal weakness is more as compared to proximal, and extensor are more involved as compared to flexor. And you will have a low motor neuron variety, meaning you will have a atrophy, wasting. You will have a involvement of the reflexes. Nutan. Good. Good. That's it. So you will have a extensor more involved as compared to flexor. You will have a atrophy. You will have a wasting. Plantar reflex will be usually preserved, and you might have absence of reflexes if that root is being involved. So ankle jerk may be absent if you got involvement of alpha S1. Autonomic nervous system is sometimes involved, and the commonest finding is orthostatic hypotension. Putting together, they divide into positive symptom, negative symptom. No need to get panic. Positive symptoms means those are the symptoms which are present in sensory, like tingling, numbness, we call paresthesia, and hyperesthesia, while loss of sensation we call as a negative symptoms like numbness and anesthesia. In motor symptoms, fasciculation and cramps are considered as a positive symptoms, while weakness and atrophy are negative symptoms. And in autonomic nervous system, hyperhidrosis, diarrhea are commonly considered as a positive symptoms, while orthostatic hypotension, impotency, anhidrosis, constipation are considered as negative symptoms. In a irritative stage, usually you will come across what we call as a positive symptoms. In paralytic stage, you will come across negative symptoms. So tingling, numbness, dysesthesia, hyperesthesia, hyperalgesia will be positive symptoms, while here numbness and loss of sensation, or we call anesthesia, common in paralytic stage. If a posterior column is involved, band-like sensation we call as a radiculopathy, quite common. Across the toe and legs in a positive symptoms, while ataxia will be loss of sensation, and that will be in a what we call as a negative symptoms, or we call in a paralytic stage. Motor we have already mentioned, cramps and fasciculation, weakness and atrophy in a negative symptom, this will be positive. And the autonomic also we have mentioned, hyperhidrosis, heat intolerance, sweating, etc. While here impotency, bladder dysfunction, bowel dysfunction, orthostatic hypotension, and ankle jerk in case of a irritative will be normal, while in case of a paralytic stage it will be absent. Other finding which you come across, we have told you cranial nerve findings very common in a person with diabetes mellitus and even in case of GBS. We already mentioned motor, sensory and mixed variety. Maybe symmetrical, maybe asymmetrical. Distal is more involved as compared to proximal. Maybe confined to only nerve, or maybe confined to plexus, or maybe confined to radical, or what we call posterior nerve root or anterior nerve root, spinal nerve root. And whenever the sensor is being involved, you start getting trophic changes. And in autonomic, we have already told you, postural hypotension, very common. Nerve may be thickened in case of diabetes, in leprosy, amyloidosis, etc. Trophic changes are quite common in certain groups, particularly say in case of sensory involvement. So you can have a pain and temperature loss, hyperalgesia, deep tendon reflex are normal, proprioceptive sensation may be normal, and you can have trophic ulcers with deformities. And whenever you get a strong family history, you got deformity in foot, do keep it in mind, Charcot-Marie tooth. This already we have discussed. This is for a summary. I've put this. Always try to find out it is motor, sensory or mix, whether it is symmetrical or asymmetrical, whether it is upper limb or lower limb or cranial nerves involvement, acute, chronic, subacute, relapsing, remitting, etc. It is static or progressive, with past medical history, family history, drug history, exposure, etc. I'm going little faster. Same, we have already discussed before, pattern of involvement, mononeuritis multiplex, or we call polyneuropathy or plexopathy, unilateral or bilateral, symmetrical or asymmetrical, proximal or distal. What is more involved? Pure sensory, pure motor or mix. Upper limb more involved as compared to lower limb, or pure upper limb involvement, pure lower limb involvement. Autonomic involved or not, cranial nerves involved or not, acute, subacute, chronic, relapsing, etc. Bilateral, symmetrical or asymmetrical, distal, etc. So some of the causes of pure sensory, diabetic most common, and another is nutritional deficiency, that is thiamine and B12 deficiency. Do keep it in mind. Another common is leprosy. These three comes topmost on the list. Pure motor, Guillain-Barré, porphyria. Diphtheria is not very common, but nowadays it is also seen in the children. Another common is botulism and late toxicity, and among hereditary, Charcot-Marie tooth. Autonomic nervous system involvement very frequently in diabetes and amyloidosis, but diabetes comes topmost on the list. Another common you will come across is nutritional deficiency, that is B1 deficiency, which is another very common. And then comes what we call as chemotherapy, like vincristine. In Guillain-Barré also you can come across autonomic nervous system involvement. Alcohol, not very common, but once in a while, even in alcohol also you can have autonomic nervous system involvement. A severely painful neuropathy we call small fiber neuropathy, classical in case of diabetes mellitus and vasculitis. These two comes topmost on the list. And then comes another is alcohol and nutritional. Isonex, not very common, but a person who is on a long-term treatment for tuberculosis can come to you with even a painful neuropathy. While pure sensory, we already mentioned here, diabetes comes topmost on the list with posterior column involvement. Diabetes tabes dorsalis, which is secondary due to syphilis, and then comes GBS. These three are very common with posterior column involvement. And then you can think in terms of a chemotherapy like cisplatin, not very common. Mononeuritis, different varieties. Mononeuritis can be radiculopathy, entrapment neuropathy, or we call nerve compression. Diabetes, vasculitis, traumatic injury, lead, leprosy, etc. comes in a mononeuropathy. Mononeuritis multiplex, again diabetes, HIV and leprosy is topmost on the list. And in polyneuropathy, again diabetes and alcohol comes topmost on the list. So keep all this thing in your mind, it will help you a lot. There are many more causes. I have not included all those. Some of the common compressive neuropathy, classical example is carpal tunnel syndrome. Another common is Bell's palsy, and third common is sciatica. These three are very common. Then you can come across multiple other like cubital tunnel, that is ulnar nerve. Then you can got radial nerve involvement at spinal groove, we call a Saturday night palsy. Peroneal nerve at fibular head, we call foot drops, etc. Depending upon acute onset, subacute onset, chronic onset, I'll mention again here, we have already mentioned some of those. In acute onset, classical example is Guillain-Barré acute intermittent porphyria. These two comes topmost on the list. And then comes we call critical illness polyneuropathy, which is quite common in ICU. Very frequently you see in ICU. Another common is diphtheria. Another we come across in a chronic variety is what we call is a demyelinating inherited neuropathy, CIDP, that is again in chronic. Ischemic neuropathy will be very common, and that will be in periarthritis because secondary due to vasculitis, that is diabetes and collagen disorders like rheumatoid arthritis and polyarthritis nodosa. So these are some of the conditions which should be kept in mind. Again, critical illness polyneuropathy is a variety which you will see very frequently in an ICU. We call in ICU acquired weakness. It is also called as ICU acquired weakness. So very frequently person is admitted to ICU, and on second or third day you start having some sensory symptoms, and person starts developing a critical illness polyneuropathy. Another variety in ICU acquired weakness is critical illness myopathy, which is more involvement of a muscle rather than peripheral nerve. So you must keep this thing in mind. So in a CIP, you can have a distal more involved, axonal more involved, sensory and motor can be involved. It is very frequently flaccid polyneuropathy variety. So you should keep this thing in mind. There are certain factors which are responsible for CIP, like a person who is admitted for sepsis, SARS, hyperglycemia, multi-organ failure, person who is on a mechanical ventilators, organ transplant, person who is on steroid, or he is on a drug like aminoglycosides, extensive burns, a person is totally immobile, etc. We don't go into detail regarding a pathophysiology. Now I am going through one variety, what we call as different types of fibers. This is a better diagram, I'll go through that particular. So large fibers and small fibers. Large fibers are thickly myelinated, and that consists of motor fibers, we call as A alpha and A alpha beta. One variety of a sensory fiber which are myelinated and which we call as A alpha and A beta, and that carries touch, vibration and position sensation, we call as a posterior column. So large fibers are mainly myelinated fibers, which are motor fibers which supplies muscle, and there are myelinated fibers which belong to sensory system, we call as a posterior column fibers. So these two are large fibers. So whenever a large fibers are involved, you will have a motor with or without involvement of posterior column. While small fibers, which are thinly myelinated fibers, which belong to sensory system, which is for pain and temperature, which are small fibers, which are thinly myelinated. Pain fibers and temperature fibers are good number of time unmyelinated, and autonomic fibers are usually unmyelinated and they are called C fibers. Pain fibers which are unmyelinated, they are also called as a C fibers. While thin myelinated, which carries cold temperature and little amount of pain sensation, those are called as A delta fibers. So whenever you get a small fibers involved, you will have a pain and temperature gone, and you might have involvement of autonomic nervous system. And these fibers, autonomic nervous system, are always unmyelinated, so chance of recovery is very, very negligible. Hence, usually they are irreversible damage. While motor fibers involvement and sensory fiber, which is a posterior column, the chance of recovery is more because they are thickly myelinated fibers. So chance of recovery is better. So same thing shown here. Large myelinated motor and sensory, and among sensory posterior column. Small myelinated fiber, sensory fiber, which are for touch, pain and temperature, and autonomic fibers. And also unmyelinated fiber can be sometime sensory, particularly pain fibers and autonomic fibers. So small fibers, neuropathy will usually be these two. And when you get involvement of these two, the chances of recovery is usually less because they are unmyelinated or thinly myelinated fibers. And classical example of a large myelinated fiber involvement is subacute combined degeneration, and small fiber involvement is of diabetes. That's why we very frequently say in a person who comes to you with a small fiber involvement, that is loss of pain and temperature sensation in distal, which is due to diabetes, usually recovery chances are less. There is another thing we call as what we use a word is axonal damage or demyelinating damage. So whenever there is a damage to ganglia, we call ganglionopathy, which is mainly involvement of the sensory posterior root ganglia. And whenever that ganglia is being involved, the chances of recovery is usually less. If motor neuron is involved, again chances of recovery becomes less. Autonomic nervous system being involved, chances of recovery is again less because they are unmyelinated fibers. So whenever you get a small fiber involved, usually the word utilized is dying back neuropathy. So chances of recovery is very, very minimum. In proximal, or we call as large fiber getting involved, they'll come with motor involvement, we call weakness or reflexia, distal wasting more as compared to proximal. And if you have got involvement of the pain and temperature with autonomic nervous system involvement, it is involvement of the small fibers. And along with large fiber, you get involvement of the posterior column as far as sensory system is concerned. Again, these are thickly myelinated fiber, chances of recovery is there. The classical example of ganglionopathy, which is involvement of the posterior root ganglia, is subacute combined degeneration. Chances of what we call as anterior horn cell involvement is motor neuron disease, and classical example of that is amyotrophic lateral sclerosis. And classical example of autonomic neuropathy involvement is concerned is diabetes mellitus. GBS is a classical example of involvement of the posterior column and what we call as motor fiber involvement, demyelinating variety. Subacute combined degeneration is another group which can be involvement of the motor, we call radiculomyelopathy, motor as well as posterior column involvement. And another example is diabetes, and diabetes is more of small fiber involvement, more common as compared to large fiber involvement. What is not peripheral neuropathy? One, intermittent numbness. If a person is telling you in between is completely normal. Jump numbness. Numbness of one half of the body. Numbness of one limb. It is less likely to be peripheral neuropathy. When neuropathy is not due to systemic disease like diabetes, if it is unilateral, if it is bilateral and asymmetrical, if it is predominantly only in upper limb, starting from upper limb or predominantly in upper limb, confined to only one nerve, particularly mononeuropathy, less likely to be systemic. Classical example of systemic is diabetic and nutritional neuropathy. Proximal more than distal, always less likely to be systemic causes like diabetes and now diabetic nerve involvement and B12 deficiency. This is one example, 45-year female, non-diabetic, intermittent numbness, pain of both feet of 1 year duration, not affecting daily activities. On examination, no neurological deficit. Further history, episodic headache, gastric complaint, neck pain since last 2 years. Diagnosis, it is not peripheral neuropathy. No need to do a nerve conduction studies. No need for gabapentin or B complex and does not require even amitriptyline. So do keep it in mind. Good history, good examination, proper diagnosis will help you. Among investigations to find out the etiology, CBC, HbA1c to find out diabetes, B12 to find out nutritional deficiency, ESR in a case of inflammatory disorders, other investigation like ANA, HIV, hepatitis panel, etc., urine analysis, hemogram, PPS, postprandial, HbA1c, LFT, creatinine, B12 level to rule out hypothyroidism, TSH, etc. And when you want to differentiate between myopathy, neuropathy, radiculopathy, etc., nerve conduction study, very important. EMG mainly to rule out the muscle disorders from neuropathy. Skin biopsy and nerve biopsy is not commonly required. It is required in a hereditary disorders, some of the hereditary disorders, or in case of what we call as certain varieties of neuropathy like leprosy, amyloidosis, where histopathological diagnosis is required. MRI of spine and brain is required when you suspect central nervous system involvement of or spinal cord involvement in combination with neuropathy. So non-invasive technique, nerve conduction study and EMG are very important, and nerve biopsy is not commonly being required. It is mainly required to find out whether it is axonal degeneration or demyelinating disorders, etc. So EMG combined with nerve conduction study called electroneuromyography, that is combination of EMG with nerve conduction study, and it is very important to diagnose a neuropathy, even myasthenia, whether it is sensory, motor or both, whether it is axonal or demyelination, it is symmetrical or asymmetrical, it is mono or multifocal. Needle EMG is required for motor neuron disease and even for diagnosis of multifocal motor neuropathy with conduction blocks. These are all the different conditions where you will require EMG with nerve conduction study, or when you do both together, it is called ENMG. So there are certain limitations because proximal involvement, small fiber involvement, subclinical involvement, you might find little problems. I am not going into detail. Even I find difficulty in these groups. So nerve conduction study, biopsy, are important in certain groups. Biopsy is very helpful in amyloidosis, vasculitis, leprosy, sarcoidosis, and to identify whether it is demyelinating or axonal neuropathy. Now biopsy will be also helpful in certain groups like vasculitis, leprosy, amyloidosis, leukodystrophy, sarcoidosis, demyelinating or axonal degeneration, etc. So I end my lecture here. I thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. And I know that this topic will be helpful to you in your everyday practice. As well, it will be also helpful to you in your exam and also in your theory as well as oral exams. So do go through this. If you like this lecture, this is mainly for educative purpose. If you like this lecture, please press button like and do subscribe and share with your friends also.